Now, after looking at all these important technical points, now let us discuss what are the signs of airspace disease. The lung diseases are broadly categorized into airspace disease and interstitial lung disease. Interstitial lung disease usually involves the interstitium of the lungs, and this is not a topic of discussion today. So today we'll be discussing basically the airspace diseases, and the important indicators are consolidation, airspace opacity, a fluffy opacity, or infiltrative lesions, and collapse or atelectasis. So consolidation is described as any opacity which causes obscuration of vascular markings, and you can see the air bronchogram and bronchiogram within it. An airspace opacity is any opacity with the radiolucent airways seen within it. A fluffy opacity is like cotton wool, and these are interspersed with the aerated areas of the lung. The infiltrates are very tiny lesions which do not follow any pattern. They are randomly arranged, and they are often referred to as nodular infiltrates. And we all know about collapse and atelectasis. It is the involvement of the lung or loss of pneumatization of the lung along with loss of volume. In consolidation, again there is loss of pneumatization, but there is no loss of volume. So this point, volume loss confirms collapse rather than consolidation. So now when we read the chest radiography, we all read psilocybin. So now let us understand what is psilocybin. Psilocybin is an indicator of a airspace disease, and it refers to obscuration of normal borders of the heart and diaphragm that is seen on the chest radiograph. Whenever there is a siloing of one border and there is collapse, so this opacity will have a sharp edge along the fissure. So this psilocybin helps us in interpreting whether there is, which lobe is involved, and whether there is consolidation and collapse, and that we will see in subsequent slides. So now based on this psilocybin on the right side, if the right hemidiaphragm is not visible, it is obscured, think of a right lower lobe involvement. If the right cardiac border is not seen or it is silhouetted, then think of a right middle lobe involvement. Similarly, on the left side, if the left cardiac border is obscured or is not visible, think of a left lingular lobe involvement. And when the left hemidiaphragm is not visible, think of a left lower lobe involvement. There is one peculiarity of the left lower lobe involvement, specifically left lower lobe collapse, that it is often seen as a sharp triangular opacity in the left paravertebral location, and this opacity is seen through the heart shadow. So once we look at the lateral radiograph, we look for fissures. So if there is a horizontal fissure, it corresponds to the right lung, and we see the oblique fissure on both right and left side. So the part of the lung behind the oblique fissure corresponds to the lower lobes. In the right lung, the part of the lung above the minor fissure is the upper lobe, and the part of the lung between the minor and the oblique fissure is the right middle lobe. Whereas on the left side, there is no such distinction, and the lingular lobe is considered as a part which overlaps the cardiac shadow. So now, once we know what is consolidation, we should also know what is lobar collapse. And often the lobar collapse is determined or diagnosed by seeing the ancillary signs or the signs of collapse. So what are the signs of loss of volume and collapse? It is pulling of the pleural fissures, that the fissure is pulled ipsilaterally to the opacity. Then the collapse can appear and disappear rapidly. For example, if we see the today's X-ray, there is no opacity, and suddenly on the next day, if we see an opacity, think of collapse rather than of the consolidation. Similarly, if it disappears, one should think about it. The ancillary signs are ipsilateral mediastinal shift, ipsilateral raising of the hemidiaphragm, the decrease of the intercostal spaces on the side of the opacity, and at times there is a vague increase in the radiodensity of the lungs. So now let us see few examples. So in this chest radiograph, we see that there is a sharp opacity which probably corresponds to the right minor fissure. We see that there is a slight pulling of the trachea to the right side, and this is homogeneously opaque. Next day, when the same X-ray was repeated, we could not see that opacity. So this can be only with a collapse rather than any consolidation. So this was a case of a right upper lobe collapse. Here in this case, we see an ill-defined opacity which is neither obscuring the right cardiac border, neither the right hemidiaphragm. So we could not be sure whether it is consolidation or collapse. But when the right lateral view of the chest in the same patient was taken, we could see a triangular opacity which was overlying the cardiac shadow. So this was a case of a right middle lobe collapse. Another case where there is homogeneous opacification of the left lung in the middle and the lower zones, we see that there is ipsilateral mediastinal shift. So we know that there is some collapse, but we are not able to interpret whether it is upper lobe or the lower lobe involvement. So when a lateral view of the chest was taken in this case, we could see that the entire oblique fissure was pulled anteriorly and there was homogeneous opacity anterior to it, signifying that this was a left upper lobe collapse and the left lower lobe was hyper inflated and hyperlucent. Similarly, in this patient, in this X-ray does not show any opacity, whereas when within a day when the next X-ray was done, we could see that there is a near homogeneous opacity in the left lower zone obscuring the left hemidiaphragm. So this was a case of left lower lobe collapse. So remember, the collapse can appear and disappear within a day, but the consolidation takes 5 to 7 days to change its appearance. So now coming on to the signs of pneumonia. So radiologists often like to report pneumonitis rather than pneumonia. So what are the signs of this pneumonia? So presence of Air-Bronchogram and Air-Bronchogram, which means there is consolidation. Presence of positive silo sign, again this tells us which part or which lobe of the lung is involved. Then there are certain signs by the name of spine sign and dense hilum sign. We'll look in the subsequent slides how we diagnose them. And there are certain ancillary signs, any sign of airspace disease including collapse and appropriate clinical scenario. This is very, very important because it gives us a hint whether what type of disease we are dealing with, because even if I report pneumonitis, I cannot at times tell the etiology. So that comes from the clinical scenario. So now what is Air-Bronchogram? So in this patient, we can see that there is a near homogeneous opacity in the right upper lobe and we can see the air-filled right upper lobe bronchus, which is dividing into the segmental bronchus. So this is Air-Bronchogram. Similarly, in another patient, this radiograph shows a large opacity in the left upper lobe, which looks like mass lesion. But when we see this Air-Bronchogram, we are sure that this is not a mass, but this is just a consolidation. So Air-Bronchograms are rarely seen in bronchogenic tumors or carcinomas. Now, if you look at this chest PA view, we see some opacity, which is neither obscuring the right dome of the diaphragm, neither obscuring the right cardiac border. So is it some disease, or is it pericardiophrenik angle fat, or is it hiatus hernia coming from the abdominal cavity? When a chest lateral view of the chest was done, we could see that there is a opacity in the lower part of the right lung adjacent to the basis, adjacent to the costophrenic angle. So by corroborating the two radiographs, we can say that this is a case of a right lower lobe consolidation. As we go down on the spine, the lucency should actually increase. But here what has happened is there is a sudden increase in the density of the lungs, and this is known as a spine sign, positive spine sign, where I cannot see the spine that well through the lungs. Now, in this radiograph, we see an ill-defined radiodensity all around the right hilum. I can see a tapering pulmonary artery, but all this doesn't appear to be a mass. I'm not sure whether it is lymphadenopathy, is it pneumonitis, what else it could be. So when a lateral view of the chest was done, we could see that the opacity is lying posteriorly on the spine, and so it was a consolidation of the superior segment of the right lower lobe. And here what we can see is a dense hilum sign on the PA view and a positive spine sign on the lateral view, which confirmed that this is not a mass but just a consolidation. Now, we all know that the opacity of the lungs is not only because of the air within the lungs, but because of the structures that the X-rays pass through. So if any of these structures are removed from the beam, the lungs might appear more lucent than the other lung. For example, if a breast cancer patient has a mastectomy on the right side, so the right lung will appear more lucent than the left lung. Similarly, if there is a swelling on the anterior or the posterior chest wall, that side lung will appear more opaque. However, in this patient, what we can see is a homogeneous increase in radiolucency, and this was because of a congenital deficiency of the pectoralis major muscle in a patient with Poland syndrome.